It is important to note that this research study predates the original 1996 consort statement and gold standard for researchers. Just by reading this concise title, A Controlled Trial of Intravaginal Estriol in Postmenopausal Women with Recurrent Urinary Tract Infections by Drs. Raoul Raz and Walter Stamm, you know what this article is about. You know the research method, you know the intervention, you know the subjects, and you know the research problem. The abstract successfully synthesizes the entire research project by dividing the information into 4 sections: background, methods, results, and conclusions. The research problem is clearly defined in the article's first paragraph. 10 to 15% of women over 60 have frequent urinary tract infections. In young women, estrogens maintain a low vaginal pH, encouraging the good bacteria, such as lactobacilli colonization in the vagina, thus inhibiting the growth of uropathogens. After menopause, vaginal pH increases due to the lack of estrogen, creating a perfect environment for uropathogen growth, causing urinary tract infections in many women. The article mentions 2 previous studies involving a vaginal cream or oral medication and how they lower vaginal pH and may reduce UTIs. But these studies had poor research designs, small sample sizes, were not random or blind, and didn't have placebo groups. The authors felt the hypotheses were valid, but their testing methods had several validity threats the medical community could not ignore. Consequently, Drs. Raz and Stamm implemented an 8-month, randomized, double-blind placebo trial with postmenopausal women using intravaginal estriol cream to answer 2 questions. Will estriol be more effective than placebo in reducing urinary tract infections in postmenopausal women with recurrent UTIs? And what are the effects of estriol on vaginal flora? Out of 23 peer-reviewed primary sources, 19 were current articles. 6 citations were mentioned in the introduction, but it was not until the discussion section that additional research was disclosed. The doctors followed exemplary criteria for choosing subjects for the trial. Postmenopausal patients with UTI issues of an infectious disease clinic in Israel were selected for the investigation. The article included an extensive list of pre-existing medical conditions, excluding certain women from the study. The doctors reduced validity threats by ensuring that the 93 women followed the study's strict guidelines and procedures. The subjects were required to apply estriol cream nightly for the first 2 weeks, and then only twice a week for the duration, which is a realistic and manageable requirement. Daily journal entry and monthly doctor visits may have been more problematic for the subjects. 28% of the women in the estriol treatment group and 44% of the women in the placebo group did not complete the 8-month study. The doctors listed medical complications and noncompliance to the research methodology to explain the study dropout rate. The doctors used a true experimental design, employing a stratified random pre-test, post-test control group design to alleviate internal validity threats. Since the women were experiencing health issues, they had a vested interest in participating in this study. The authors thoroughly described the microbiologic techniques used during the medical testing phase of the study. They also used several statistical programs to ensure the data was statistically significant. Table 1 clearly shows a noticeable dropout rate between the 2 groups. It is very interesting to note that more than 1/2 of the women in the placebo group dropped out due to recurrent urinary tract infections requiring antibiotic treatment, while the treatment group had 0 dropouts. Table 2 and Figure 1 detail the Wilcoxon and Kaplan-Meier analyses. Upon closer inspection of Table 2, we noticed a few discrepancies we would like to address. The Wilcoxon test showed that the annual median incidence of urinary tract infections for the group given estrogen was significantly lower than the placebo group. Table 2 uses monthly figures and yearly figures with no explanation, and the article does not clarify whether researchers used annualized median incidence in an 8-month study. Table 2 indicates that the researchers used the sample size at the start of the trial, rather than the final sample size in their analyses. The total person-month of observation based on the final sample size calculations are listed on the table on the right. The sample variable affects the p-values. Therefore, we question the validity of the data analysis. The paragraph discussing Table 2 and Figure 1 also describes 4-month results. These data are not listed on any table or figure and are not specifically associated with the Wilcoxon test or the Kaplan-Meier analyses, further complicating what the authors are trying to state. The study reveals that none of the women at the beginning of the study tested positive for lactobacilli. However, by the end of the trial, lactobacilli are present only in the Estriol group. On the other hand, where bacteria were present in both groups, only the Estriol group saw a statistically significant decrease in the rate of the colonization of uropathogens. The vaginal pH fell notably with the treatment group, whereas it changed little in the placebo group recipients. Thus, the authors claim that while the study included a small sample size, there appeared to be a relationship between the vaginal colonization status and the risk of urinary tract infection. Although this research study occurred prior to the original consort statement, we feel that Raz and Stam appropriately designed and conducted this randomized, double-blind, placebo-controlled trial. Selection bias, one of the most common internal validity threats for research studies, was present in this study. The researchers used strict scientific methods and consistent testing instruments to measure the subject's vaginal flora changes over the course of the study. Clinicians administered the monthly tests, further decreasing the possibility of error. Researchers conducted standard statistical analyses. However, the article did not include mean and standard deviation, making it impossible to calculate effect sizes for comparison with other research. While the authors discussed relevant research studies in their discussion section, we felt this information would have been helpful to know at the beginning of the article. The authors conclude that their data results confirm their hypotheses. The intravaginal administration of Estriol prevents recurrent urinary tract infections in postmenopausal women by modifying the vaginal flora. The total person-month of observation numbers do not match with either of our start sample or end-of-study sample size calculations, causing us to question the validity of their p-value. The vaginal pH changes that occurred in both groups over the course of the study would have been easier to visualize had the authors graphed the data rather than listing it in a table. In the final paragraphs of the article, the authors discuss several studies related to oral estrogen and numerous side effects, and suggest further evaluation of oral estrogen. However, this trial studied estrogen cream, not oral estrogen. Thus, the oral estrogen recommendation is not relevant for this article. A pharmaceutical company provided partial funding for this study, which may be why the authors included this information. We chose this article for a number of reasons. We are fast approaching our golden years, and the subject is of particular interest to us. 20 years later, the results of this study continue to benefit women. Estrogen cream is readily available in our local drugstores. We no longer have to go to a doctor for treatment. Colleen's research focus is teaching instructors and students digital storytelling for education and research. Angie's research interest is online learning, which often incorporates videos to facilitate learning. By presenting this article critique in video format, we are able to use this experience to enhance our videography skills.
So remember, like the pH of a fine wine, so should your vaginal environment be. Cheers!